This lecture will go over Chapter 16, cholinergic agonists and antagonists. It begins on page 211. So first we'll start off with cholinergic agonists. Cholinergic agonists are drugs that stimulate the parasympathetic nervous system. They mimic the parasympathetic neurotransmitter acetylcholine. Now, if you remember, with the sympathetic nervous system, the word adrenergic was your clue that you were somehow dealing with the sympathetic nervous system, whether it was an adrenergic agonist or antagonist. When you see adrenergic, think of adrenaline, think of sympathetic nervous system. For the parasympathetic nervous system, cholinergic is your key term that clues you into you're dealing with the parasympathetic nervous system, because the neurotransmitter for the parasympathetic nervous system is acetylcholine. See that CHOL? That's your clue that you're dealing with the parasympathetic nervous system. It's your job when you see that CHOL in medications and things of that sort. It's your clue to the parasympathetic nervous system, but you need to know, are you dealing with an agonist or an antagonist? The two cholinergic receptors are the muscarinic and nicotinic. Two types of cholinergic agonists are direct acting or indirect acting. Direct acting does exactly what it says, acts on the receptors to activate tissue responses. Indirect acting, we're not going to talk about too much this chapter, but just so you know, it inhibits the action of the enzyme cholinesterase. So you see that ASE, that's your clue that you're dealing with an enzyme. In this case, cholinesterase is the enzyme that would break down acetylcholine. In your textbook, you have the diagram of the effects of cholinergic agonists, and this is something that I expect you to know. We did cover those in lecture, so I'm just going to fast forward past these next couple slides. Again, we hit on these. It's the opposite of the sympathetic response, and you are expected to know how those cholinergic agonists affect the body. This is just a little diagram showing a direct acting cholinergic agonist. It's when the drug itself actually activates the receptor sites. And direct acting cholinergic agonists primarily are selective to muscarinic receptors, which are located in smooth muscles of heart, GI, GU, and glands. The first direct acting cholinergic agonist we're going to talk about is bethanyl chloride. It's the bottom drug listed there. And you know how it ends in that CHOL. Again, that's your clue that you're somehow dealing with a medicine that interacts with cholinergic receptors. You have to know if it's a cholinergic agonist or antagonist. In this case, bethanyl chloride is a cholinergic agonist, also known as a parasympathomimetic, or something that mimics the parasympathetic system. And the use of bethanyl is to increase urination. So it would be used to treat people who are experiencing urinary retention or neurogenic bladder. Another cholinergic agonist you will be responsible for knowing is metoclopramide. Brand name is Reglan. It's used to increase gastric emptying time. So it's used to treat gastroparesis. If you don't know the terms, look it up. Nausea and GERD. And again, it works by enhancing gastric motility and accelerating gastric emptying time. So it keeps pushing the stomach contents forward. And you'll use it in the clinical setting frequently for nausea and gastroparesis and also GERD. Then finally, the final drug or medication listed there is pilocarpine, which is used to constrict pupils. So again, constricting pupils is miosis. Pilocarpine is a cholinergic agonist, so it's encouraging that parasympathetic nervous system, and specifically an ocular drug used to constrict pupils. So let's talk a little bit more about bethanyl, which is your prototype drug on page 213. Some side effects include blurred vision and miosis. So again, the patient is taking this to treat urinary retention, right? But since it's a cholinergic agonist, it's encouraging that parasympathetic system to do what it does during rest and digest. Miosis is a side effect of it, right? Because pupil constriction would be something that would happen during rest and digest when that parasympathetic system is engaged. Going along with that, hypotension, bradycardia, increased salivation, gastric acid. That's again that rest and digest. This is the digest part of the system at work. Nausea, diarrhea, and abdominal cramping, bronchoconstriction, and then finally cardiac dysrhythmias. But again, a lot of those side effects you should recognize just because you understand what the parasympathetic nervous system does and how the medication is a cholinergic agonist, what you would expect to see in your patient. So contraindications, bradycardia, hypotension, right? Depending on how low they are, we know that this medication could cause them to go lower. So if I have a patient that's super hypertensive and they're due for a Bethanyl, for a dose of Bethanyl, I would probably want to make sure I'm assessing vitals, getting BP, pulse immediately before giving it. And if the blood pressure is low, I'm going to need to hold it and contact the provider, because if I give it and drop the blood pressure even lower, I could cause problems for my patient. COPD, right? Any respiratory issues is a problem because the cholinergic agonist can lead to bronchoconstriction. And what I'm not seeing on the slide, but definitely worth noting, is urinary tract or intestinal obstruction. So if I have a small bowel obstruction or some sort of urinary tract obstruction, this Bethanyl would be contraindicated because as a cholinergic agonist, it's going to put my body in that rest and digest stage, and it's going to make me want to urinate, right? My body's going to try to urinate. My body's going to try to move along to increase peristalsis in that rest and digest state. So that could be very problematic if my patient has an obstruction and then I take a medication that sort of increases peristalsis or increases the patient's desire to urinate when there's a complete blockage there. Going back one slide just quickly to talk about pilocarpine. Again, it's the cholinergic agonist that constricts the pupil of the eye. It's important to know that this is used to treat glaucoma by promoting miosis. So all I want you to know, just a real basic about glaucoma. We haven't got to the eye section yet, I know that. But with glaucoma, pupil dilation is bad. Pupil constriction is good. So a medication that constricts the pupil wouldn't be contraindicated for glaucoma. It may be used to treat it. But just know that mydriasis would be bad for the patient with glaucoma. Moving forward then to the nursing process box. You have a nursing process box on 214. Go ahead and pause the video and look through there and pull out what you think is most important for you, the nurse, to know. All right, in terms of nursing process for Bethanyl, so under assessment, obviously vitals, when we're looking at vitals, get a baseline for future comparisons and then watch how it's trending while you're medicating the patient. Assessing urine output, because again, we're going to want to be tracking that since the patient is taking this medication to treat urinary retention. We want to see what they're able to put out. Obtain a history of health problems such as peptic ulcer, urinary obstruction, asthma. I know we talked about urinary obstruction and asthma already. Peptic ulcer, take a second to pause the video, think about why peptic ulcer might be a health history problem that you'd want to know about. And if you thought about peptic ulcer, first of all, you need to be able to recognize what it is. So it would be a GI ulcer, peptic ulcer. And again, when you're taking Bethanyl, which is a cholinergic agonist, it's turning on that rest and digest, get the increased gastric secretions. That increased gastric acid secretion can make GI ulcers even worse. So that's why we're checking on the status of peptic ulcers. Under diagnoses, the big one with Bethanyl is urinary retention. That's the reason we're giving it. So under planning, what do we expect to see? We expect to see urinary output. Your textbook says patient will have increased bladder tone after taking cholinergic agonists. Nursing interventions. Monitor for orthostatic hypotension, right? We're turning on rest and digest. The BP is going to go down. We worry about orthostatic hypotension and falls, safety issues. Ideally, give cholinergic agonists 1 hour before or 2 hours after a meal, but if the patient complains of GI upset, it can be given with meals. Record I's and O's, intake and output. Decreased urinary output should be reported because it may be related to a urinary obstruction. Monitor our labs, which you guys should be familiar with your liver and kidney values going forward. So if don't let yourself get rusty on those. Make sure you keep those numbers tucked away and you're able to use those on exams going forward. Observe for side effects such as gastric pain, cramping, diarrhea, increased salivary or bronchial secretions, orthostatic hypotension. Sometimes the tachycardia can occur with that because the blood pressure goes so low, the body tries to compensate by increasing the heart rate. I want to listen for adventitious or bad lung sounds because of those increased bronchial secretions. Top right of your nursing process box on 214, you have a lightning bolt there, important. Have IV atropine sulfate available as an antidote for a cholinergic overdose. So I mistake Bethanacol for something it isn't, and I take a handful of them. The antidote for a cholinergic agonist overdose would be atropine, which we're going to talk about, is an anticholinergic. So it makes sense that it'd be the antidote for a cholinergic agonist overdose. Early signs of overdosing include flushing, salivation, sweating, nausea, and abdominal cramps. Increase bathing and change linen if necessary because diaphoresis may occur. A possible cholinergic crisis or overdose includes symptoms of muscular weakness and increased salivation. Under patient teaching, direct the patient to report severe side effects such as pronounced dizziness or heart rate less than 60 beats per minute. So they're going to want to be checking those. Teach the patient to rise to change position slowly to avoid becoming dizzy. And now I'm going to go through here and just show you some stuff you don't need to know for this exam. We're going to cover it later. So we're going to skip indirecting cholinergic agonists. Skipping this. We are going to skip reversible cholinesterase inhibitors. We're going to hit these in different chapters, so we're not going to hit them twice. We're going to skip them for now. We're going to skip irreversible cholinesterase inhibitors. So this is going to end your first recorded lecture on chapter 16. I'll start the next lecture with anticholinergics or cholinergic antagonists.